series of Big Dreams for Small Miracles. And today we have got some very interesting topics on biomedical waste management and housekeeping, personal and inventory management, and role of purchasing department. To start with, the first session will be from Mr. Nitin Nag about a very important aspect of biomedical waste management. As we all know, as the world is suffering from COVID pandemic, we have seen five-fold increase in the medical waste management. And it is estimated that previously for each hospital bed, there appears to be about 500 grams of medical waste. Now it has increased to almost 2.5 to 4 kilo per bed. That is the cost that is actually the world is incurring on this COVID pandemic. And so warm welcome to Mr. Nitin Nag to start the talk on the biomedical waste management.
Sure. Thank you, sir. Good evening, everyone.
Kindly introduce yourself briefly, and then you
Sure.
can start the session.
Sure. Good evening, everyone. My name is Nitin. I am associated with Cloud9 Hospitals. I am the regional director for South region at Cloud9. I have been with Cloud9 Hospitals for a little under 5 years. Prior to this, I was part of Manipal Hospitals Group. I'm currently based out of Bangalore and happy to be spending the next couple of hours with you, sharing whatever little I know of this and also learning from what the other speakers are going to talk about their experiences. So primarily my talk is around biomedical waste management. Now, any waste that gets generated in any of the healthcare establishment gets attributed as a biomedical waste. Now, the common belief is that only the things that come out of a hospital are treated so, but that's not true. Even the camps and marketing activities that we do in a remote location, even those have to be handled with caution. So anything that is associated with us, anything that is associated with a healthcare establishment ends up becoming a biomedical waste and has to be treated with utmost care and caution. The purpose, all healthcare establishments are required to have a formal biomedical management process, and there is no exception to it. It is expected out of a clinic, it is expected out of a research institute, it is expected out of a healthcare establishment of all shapes and sizes and whatever discipline that we are dealing with. And there is really no exception. And any exception to that will be treated very, very seriously by the authorities. Now, the purpose of having this formal process is mainly to ensure that as healthcare establishments, we treat the waste that we generate with utmost care and caution. Not only is it incumbent on us to be doing this for the safety of our own staff, but it is also incumbent on us to be doing this for the safety of the patients who come into our establishments. The quality of this is, you can typically measure with the amount of hospital-acquired infection rates that get measured in most of the hospitals. Our objective always has to be to make sure that that is zero and it is maintained that way in whatever time frame that we measure. Of course, there is the larger aspect in terms of us trying to be responsible while dealing with the hospital waste, because it does have an impact on the society at large, and there is a larger environmental concern as well. So the entire spectrum of concern or the entire spectrum of people impacted starts with our own staff to our patients to the society at large. Therefore, realizing that that is such is the magnitude of impact of what we generate, and if we end up mismanaging, that's the kind of impact it has on the society at large. It is extremely important for us of all healthcare establishments of all sizes to have a formal waste management process. Typically, if you look at it, there are two different types of waste that gets generated. One is biomedical waste, there is general waste. And the process that is there right now, and even if we look at NABH guidelines, the waste has to be categorized at source, and that is the best way of ensuring that a seamless management of that waste ensures post that. Unless and until it is segregated at source and it is classified, it becomes extremely difficult for people handling it post that. Which is why a formal biomedical waste management process starts with segregation at source, then collecting and then storing it in interim storage areas which are available, which will be identified and used within a hospital. And then comes the whole aspect of try partnering with a proper company with another organization, typically for transporting this onto another place from where they can be treated or disposed. Broad guideline is that there can't be an untreated biomedical waste beyond 48 hours. And this is a broad thumb rule that is used, and all establishments tend to follow this, which is also one of the reasons why, if we look at our own hospitals, there is a strong collaboration between us and the companies that help in transporting biomedical waste out of our hospitals. And that is almost like, it happens like clockwork. And many a times we don't even realize some of these people who are helping us keep the hospital up and running and making sure and enabling us to keep it safe for our patients. Uh, there are different categories of waste that get generated, and typically this is available as part of any guideline document that you would review, which are made available by the Central Pollution Control Board. The more common form or the more tangible form of segregation that we would encounter is this. If you look at most of the hospitals around, clearly they have this process well defined. There are color codings that are done for the baskets that collect different forms of waste, and this color coding is in this form. And most of the hospitals that are there around of reasonable size are, you can see it in action. You can, as you walk around, you will see it, this pretty much available in every nook and corner of the hospital. And over the last, I think, 9 years that I have been associated with the industry, I have seen the improvement in terms of compliance across all establishments that I have, come in touch with. Improved leaps and bounds over the last 9 years, and this is something that's a good sign, because it's evident that all hospitals and healthcare establishments are taking this extremely seriously. This is more, I thought instead of me showing all theoretical slides in terms of what is the categorization of waste, how it's handled and all that, I thought I would give you a snapshot of a day in my own hospital in terms of how the entire process unfolds. As you can see, there is a collection area, there is color segregation at the collection itself. These are the people who make sure that we keep this process tight. They help us in managing this entire process day in and day out selflessly. There is a separate holding area from where it is weighed and then transported out on a regular basis. So with regards to transportation, we have vendor who comes across all our network, picks this up and then takes it away. And so that almost is like a well-oiled, well-defined, and a process that works like clockwork. And it needs to be so. Otherwise, many of us get into trouble in just this small aspect. And this small aspect will tend to show up in terms of, the impact on the patient safety. Now, with regards to the rules that are governing this process, there are many of them. There is a central rule that has come in place, and it's as part of CPCB. However, there have been instances where some states have gone ahead and then made some variations as well. So it would be good for whosoever is establishing a healthcare establishment for them to look at the central guidelines and also maybe check if there are any state level deviations. It's always good to do that. It only helps us kind of make sure that whatever we implement is really watertight. And with regards to the activism that is shown, this is one aspect of government which is extremely active, and they are always on. Uh, can you see the slide?
Yes, sir. Yes, sir.
Okay. So with regards to the government, they are so active, and in fact, owing to COVID,
Sorry,
as
actually, slides I am not getting, sir. I can see your video.
okay, I'll just share it again. Now?
Uh, yeah,
Yes,
it's coming.
yes.
Now
Okay.
we can see the slide. Yeah.
Okay. Okay. All right. Now, with regards to how seriously the government takes this, the case in point being that owing to COVID, as recently as April 2020, they came up with further enhancement to the guidelines, which was already well defined. They enhanced it. And the enhancement was more in tune because of the pandemic that we have in terms of how the waste that gets generated from the COVID affected patient, how that needs to be treated. So there was a separate enhancement that was done. And that is how seriously the government looks at this, and this is a extremely good example in terms of how actively they have been and how quick they are to respond to an external situation like this. So if any establishment is mandated to go through these guidelines, look at what is the relevant compliance levels or norms that are required, documentation that are required from us, and make sure that we are always at it. There is a formal documented process that needs to exist in hospitals. It's mandatory as part of NABH as well. Even if we weren't, an NABH compliant organization, it would still be incumbent on us to have a formal defined process which details this entire every single aspect of biomedical waste management. Again, as part of the whole guidelines that are there, there are various schedules and forms. Some of them are forms which need regular reporting as well. So, it's very much required for us to go through these schedules that are available. It will be available on the website, and you could download it and then look at it and make sure that we fill those and then keep it available on a regular basis, because this is a process that could be audited by the government authorities at any point in time, and non-compliance will be dealt with very seriously by the government. Uh, and like I was saying, non-compliance, while there is a legal aspect, because this is a law and we have to comply with as a healthcare establishment. There is also a larger social impact of non-compliance. And as healthcare organizations, as healthcare workers, as people running healthcare establishments, it's extremely important for us to be cognizant of the larger societal impact of not having this process extremely well defined and well managed. And as you can see from this slide, there are people who are always looking at us through a microscope, and that's a I mean, everyone looks at a healthcare establishment through a microscope these days. But this is something that's looked at extremely actively by various aspects of the government, various departments of the government, as well as a lot of social activists. And I have known of instances personally from my peer group where they have received notices from social activists who have seen one waste cover, a waste bag being placed in a different place where as against the norm that was to be followed. And so it's taken very seriously. So non-compliance leads to a lot of problems legally as well as socially. So that's one of the aspects that I was trying to bring out here. And Largely, I mean, this is a net summary of the entire aspect of this process that we are dealing with. While there is a legal aspect of it, we also have to understand that there is a huge environmental risk. And as healthcare establishments, it is extremely, extremely important for us not only to be compliant with the law, but also to be doing things which are in tune with the environment, which take care of environment safety and most importantly, patient safety. Even more than that, our own employee safety and our safety. One simple statistic that I would like to share from our own personal professional experience is that our own hospital acquired infection is near zero, and I think it's been there for almost 3 years now. So that is the level of seriousness we accord to this. And it's not just us, but I think it's the larger industry at large, which has to look at it this way. And, that's pretty much what I had to share as far as this biomedical waste management is concerned.
Thank you, Mr. Nitin, for the lucid talk. And especially with the COVID pandemic, it's posing a huge challenge for the entire world how to manage this medical waste. We will take the questions at the end of all the three talks. And please, you can actually share your questions either through the chat or you can ask at the end of the session. Thank you very much, Mr. Nitin. And moving on to the next talk. So, to manage the biomedical waste, housekeeping personnel play an important role, and also it is very important to manage the inventory. So to talk on this housekeeping personnel and inventory management, I would request Dr. Pawan Kumar to give a talk. And can you please start with your introduction? Thank you.
Thank you, sir. Good evening, everyone. My name is Dr. Pawan Kumar. I have been with Cloud9 Group of Hospitals in the capacity of Regional Director, looking at their business in North for last 3 years. Prior to it, I was working with Max Group for around 5 years in different capacities. I'm a trained anesthetist from PGI Chandigarh. I also practice anesthesia once in a while. But most of my work primarily encompasses operations, growth, business development for Cloud9. By education, I am a finance graduate from Indian School of Business, Hyderabad, and I am based out of Gurgaon here. And I would like to thank Dr. Kishore and Dr. Prashant for giving this opportunity to interact with you on a Sunday evening on a very interesting topic, that is housekeeping in hospitals. So me and Nitin are colleagues. A few days back, we were talking that this is one of a very different conversation that we are going to have with a group of doctors. Most of the conversations that we have with doctors pertains to their scope of work with regards to clinical piece or the financial piece. Talking about housekeeping or biomedical waste is a very rare occasion. So thank you so much. And with this, I'll just begin my presentation. So the presentation is broadly about housekeeping in hospitals, inventory and personnel management. For inventory, basically, I would like to introduce the audience to the set of inventory that we talk about in housekeeping, primarily equipments, the chemicals that we use, and the linen that we use for managing a particular patient's bed or requirement in a hospital. The second aspect is the personnel. And broadly, how does the inventory and the personnel interact in different settings in a hospital pertaining to a OT or a NICU, which is a very critical area or a very high risk area as it is graded in housekeeping parlance, or an OPD or a parking area, which is a kind of a very low risk area in housekeeping parlance. So, and a lot that I am kind of covering in this presentation is about what we do in Cloud9, which has helped us achieve two things very clearly in terms of outcome. One is a very high level of patient satisfaction with our housekeeping practices. And second, I think one of the best infection control practices and outcomes that we have achieved in the industry. So with this, I'll kind of take you through the presentation. Yeah. So I've just begun by defining housekeeping. It's basically to provide clean, comfortable, safe, and aesthetically pleasing environment. Contrary to the popular belief that housekeeping department is usually a non-revenue generating department and where money is needlessly spent without any impact on patient outcome. And typically, a manager is whenever he looks at the P&L, this is one area he usually looks at how do I save cost for a hospital, not knowing that this is probably one of the most important areas for patient satisfaction and directly linked to infection control. The scope of housekeeping primarily pertains to, apart from maintaining a cleaning of patient and public areas and maintaining a clean, comfortable and order-free environment, pest control, linen management, laundry management, safe and secure environment, which means every item should be in its place all the time. Horticulture, spill management, facade cleaning, and biomedical waste management, which Nitin has covered in pretty great detail. This is a brief outlook of equipment that we use in housekeeping. A single disc machine is the most commonly used equipment. It is precisely used for floor scrubbing, polishing, carpet shampooing, buffing, and then a vacuum cleaner. A dry and wet and dry vacuum cleaner is more commonly used. There is a high pressure jet machine which is used for cleaning the soiled surfaces. There is a multi-purpose steam cleaner that is used to kind of clean the grooves, the corners, and the floor joint. This cleaning is typically done is kind of a deep cleaning, which is usually done once in a week. Then there is a hard floor cleaner for brooming and mopping. This is the most common used equipment, which is the double bucket ringer trolley. And the other item primarily talks about all the brush, the duster, the dustpan, the mops which are used. Now talking about chemical, there is a list of chemical and disinfectants that we use for housekeeping. Tasky is one of the pioneers in housekeeping and processes, chemicals and equipment. And at Cloud9, we extensively use Tasky chemicals. The chemical selection is precisely dependent upon the visual effect of cleaning that we want to achieve, availability of literature about its effectiveness, lab report and certification of the outcome in terms of infection control practices, and the support that we get from a company for complaints or improvement. And we use Tasky extensively across all our 16 hospitals. Typically, the chemicals are code named in terms of R1, R2, R3, R4, R5, R6, D7, D10, TR101. And I have tried to kind of work at what does this actually contain in terms of chemical composition and what it's used for. So R1 is typically a bathroom cleaner. It is used for daily ceramic and surface cleaning of bathrooms. R2 is all-purpose cleaner. R3 is basically a glass cleaner. It ensures a shining surface of the glass while making it infection-free and make sure that there are no scratches on the glass. Then there is a wood surface cleaner, protects the wood while cleaning it. R4, R5 is primarily an air freshener. And there is a bowl cleaner or toilet cleaner, R6, which is comparable to Harpic that we use in our houses. Then there is a stainless steel polish cum cleaner, which is D7. It has isoparaffinic hydrocarbon. Most of the chemicals are water soluble or water based. This one is not. Then the food handling area cleaner is Sumabac D10. It's primarily a detergent based surface cleaner. And then we have a carpet cleaner, which is used for carpet shampooing. Bacillocid is primarily used for terminal or surface cleaning. So after the area is thoroughly cleaned, then bacillocid is used to disinfect various surfaces. It contains aldehyde. And then sodium hypochlorite, we all are very familiar with. It is primarily to disinfect surfaces from which are soaked or infected linen before washing or blood-stained surfaces. Now, talking about housekeeping personnel, uh, Typically, this is how the department is structured. There is a supervisor, and then there are attendants, gardener, linen attendant under him. Typically, if you talk about a 50-bed hospital with 75 to 80% occupancy spread across fourth floor or 5 floors, 60,000 square feet of area, including the outside area. Uh, and this thing will typically kind of vary from place to place depending upon what is the percentage of critical area versus total area, and how it is structured in terms of number of floors. Usually, when the floor size is such that there are 8 to 10,000 square feet on a particular floor plate, this manning holds good. As the floor sizes get small, the manning becomes inefficient. And classical thumb rule is basically you put one manpower per 10,000 square feet and in 3 shifts. So if it is 60,000 square feet, you could easily say 18 manpower is what is needed, and then there are 2 housekeeping staff, and this is how it is manned. So this is a thumb rule. While this thumb rule will kind of vary from area to area. Like for OPD area, the manning will be very different. For OT and NICU areas, the manning will be very different because those are the areas where we do not like people to move a lot. So that imposes constraint on the people. And if you have to keep a housekeeper in a small area, which is 2000 square feet and is an NICU, probably it is justified in that context. But roughly in terms of head count, it boils down to one manpower per 10,000 square feet for a average structure of a hospital like this in 3 shifts. Most hospitals typically have this manpower not on their rolls. These are primarily outsourced by the agency. This is also a cadre of manpower where the attrition is quite high. Having it through agency, one, it helps in manning adequately. Second, it gives a reasonable amount of uh, control of compliances for the labor department. So there is somebody who is dedicated looking at that compliances, and the HR department in house is not burdened with that, especially given the churn rate in this cadre. And while we kind of make sure that we are taking these people for housekeeping, we ensure that they are literate. Typically, we take people who are kind of 8th or 10th pass. They should be presentable to the customer. They are trained on grooming and hygiene levels. Uh, Most of the time, they have some basic level of the knowledge, but mostly we train them in house. So typically, we spend 7 to 10 days on getting a hang of the place and hang of the processes and the kind of work, and gradually they are supervised closely that over 15 days to 20 days they become independent workers. We ensure that each of these people undergo police verification because hospital is a very sensitive and a vulnerable area, and all of them must mandatorily undergo a pre-employment health check and an annual health check, which is also a labor department's requirement. Now, so the interaction of the chemicals, the equipment, and the personnel is typically comes in how the cleaning is scheduled in a hospital. Now, all the activities pertaining to cleaning are listed, and some activity need to happen on a daily basis. Some activities need to be happening on weekly basis, and some are scheduled like once in a year. For example, a trash or a garbage removal, a mopping or a dusting has to happen like daily. Something like upholstery cleaning or a top level dusting or a chair shampooing can happen once in 7 days or 10 days. While there is a set of activities which are annual cleaning or spring cleaning, like repairing of the wall or carpet, or a particular room gets closed for overhauling and repair. And that's essentially once in a year activity. Now, classification of a risk area, or I would say from the sensitivity of house cleaning perspective, these areas are defined. So high risk areas or high sensitivity area are typically operation theaters, NICU, SICU, IVF lab, and CSST. Medium risk area are the inpatient rooms or OPD chambers. And then the low risk areas or the common areas are corridors, lobby, common washrooms, cafeterias, offices, and stores. Now, it's important to differentiate the areas of a hospital basis the sensitivity of housekeeping requirement, precisely because from the purpose of deployment of people, the kind of activities which are carried out in these areas, the frequency of those activities, the kind of chemical and the inventory of the equipment being used. Now, the general principle followed for cleaning is that apart from just ensuring cleaning, the area has to be safe and safe from the personnel has to ensure that when they leave the area, it should be in a way it has been previously. And they have to remove the trash and the garbage, the hazardous substances, making sure electrical points are concealed. All cleaning tool and equipment has to be left safe and in working condition at the end. The cleaning agents should be available in desired container and quantity in their respective places. Cleaning is typically carried out from top to bottom and from inside out. All the cleaning material are placed back in designated places after the work is over. Typically, in most of the hotels, they have a standard photograph. So once a personnel enters a room uh, and he does the work and he leaves the room, he takes out that photographs and compares. I am leaving a room in a condition in which the room is supposed to be. And if it is not, then he goes back and makes the changes in terms of laying out the bed or settling the furniture or the wiring or whatever. Now, this is typically how the cleaning happens in a high risk area, for example, in operation theaters or an NICU. Uh, After doing a regular cleaning, the most important thing is terminal cleaning with bacillocid. And after every movement of a patient in and out of operation theater, it must be cleaned with a disinfectant. So that is pertaining to OT and NICU. And typically NICU is cleaned even if there is no movement at least 3 times a day. Now, this is how a medium risk area like an IB ward is kind of cleaned. Typically for 3,000 to 3,500 square feet, we deploy a personnel. It covers around 10 to 14 rooms. So if there are some 30 beds in a hospital, typically a medium-sized hospital, I think 2 staff in one shift are kind of completely able to take care of the place. So one staff kind of does the cleaning of the room and other staff is primarily cleaning the washrooms. And then a low risk area where it's kind of spread out. Typically uh, dusting and surface cleaning is done once a day, a floor washing is done once a day, and wet mopping is done as per the requirement. Now, inventory management, in terms of inventory management, primarily linen management is the most important aspect. And there is a concept of par level. So par level is the minimum set of goods required for smooth set of operations of services. So for example, if a hospital's occupancy is running at 70-80% and it's a 50-bedded hospital, typically that means for operation at any point of time, there should be, say for example, if we talk of bed sheets, there should be 40 bed sheets. Now for smooth operation to continue, there should be at least 3 to 4 times that many number of bed sheets available. So one set is while placed in the room, the one set is in the laundry or for washing, one set is in the transit between the laundry and the hospital, and one set is in the rack for replacement all the time. Now, this may change depending whether the laundry is in-house or whether it is coming from outside. If there is a variation in occupancy which is predicted, for example, once the dengue season hits in, then probably we have to upgrade this par level itself by 20-25% and kind of manage the occupancy accordingly. It's crucial to define the linen par level because it's like blocking inventory and money along with it. If it is set at a higher level, while at a lower level, it will produce undue operational stress for managers and patients alike. I think every day when the linen is kind of taken out for laundry, it's checked and then handed over. Any linen which is found not in proper condition, not in use, is either to go for repair or discard basis the condition of the linen. and I think precisely the laundry process in a hospital is equally crucial to maintain hygiene and infection control level. Typically, the hospital linen is washed in warm water up to 60 degrees, and the soiled linen is cleaned by soaking in 2% sodium hypochlorite, and then it is kind of sent to laundry for washing. Equipment inventory is managed and maintained just like medical equipments. They are checked on a daily basis and maintained as per manufacturer's instructions. Chemical inventory, the cleaning agent is maintained based on average consumptions and lead time of procurement. Typically, we set a reorder level. That is when we need to, what is the level of inventory left when we need to reorder, and what is the economic quantity that vendor can economically deliver, and that is the reorder quantity that we set. Um, One important aspect of chemical inventory management is dilution. So typically 2 to 5% dilution of most of these chemicals is used, and most of the housekeepers do a mistake in diluting it. So either it's under diluted or over diluted, mostly over diluted, and that is where it's a wastage of chemicals, and hence it's something where the money is kind of getting wasted without anybody noticing what is happening. So typically the company provides a diluter. Diluter, you fill in the chemical and it is attached to a source of water, and there is a way to titrate the dilution percentage, and this ensures that the chemical is used uh, appropriately or not under or overused. Thank you so much for this opportunity to kind of interact with you. I hope that I have been able to cover the very practical aspects of housekeeping for your consumption in this brief presentation, and I'm happy to take any questions. Thank you so much.
Thank you, Dr. Pawan. Wonderful presentation, and this is something which doctors don't give importance to. So thank you, Kumar.
Thank you, Dr. Prasad.
We'll take up the questions and answer after this talk. Now I request Dr. Suresh. Dr. Suresh, you're there?
Yes, Prashant, I'm here.
Yeah. Dr. Srinath. One second. Just open your presentation. Can you see the presentation?
Not yet.
Take around 5 seconds. It's fine now.
It's coming, sir.
Yeah, it's coming.
Okay. Dr. Srinath, it's coming in the laptop. It's fine. So
He needs to make it play the presentation, brother.
yes. 1 second. Yeah. So now we are moving on to the next topic, that is a role of purchase department in healthcare organization, how important it is and how crucial it is in terms of the financial aspect of the hospital. So I always call Dr. Suresh as the Shakuntala Devi of our hospital management. He is one guy who knows everything about most of the things about each and every part and corner, nook and corner, and each and every aspects of hospital management. So he can tell anytime and he can advise anytime what is best and how to beautifully can handle the situations or the problems arising in the hospital management. So I request Dr. Suresh Vishwanathan, who is the owner, founder, and managing director of SKS Hospital, which is now 500 bedded. I think you're planning to make 1,000 bedded. Correct, Dr. Suresh?
I think every time I come online, you keep increasing the number. But,
No, we
Still
know
at
that
about
you
250 beds.
will take it to the next level. So over to you, Dr. Suresh. Yeah.
Thank you. Prashant, it's still on not at full screen, and I haven't got the request control option.
1 second. Okay. Have you sent the request control?
It's not being active. It's still. Have you hit the play button on top?
Okay, 1 second, 1 second. Yeah, is it? Can you see now?
No, it's still in the edit mode.
Presentation edit. Okay, 1 second. Yeah.
Maybe it's my presentation. I think I figured it out from my screen. Is it?
Yeah, it's coming now. Yeah. We can see.
Okay.
We can see. Please go ahead. Yeah.
Okay. Hi everyone, and Prashant tends to exaggerate a bit every time he gets me online, but thank you for the kind words. Like you said, I'm the managing director of SKS Hospital. We are a postgraduate institute with several national board accredited courses, and we're based out of Salem in Tamil Nadu. The purchase department is a vital part of any organization, not just a healthcare organization, but in healthcare, it takes a particularly vital role because you're dealing again, like every other department in the hospital, we're dealing with lives, and supply chain is quite important. I apologize in advance for being very text heavy. It's just that the topic is like that, and I can't put in too many. I can't put in any fancy pictures for the purchase department unless you want me to show racks and racks of stock. So I thought we'd start with defining what is the purchase department, because I believe a lot of the audience are people who are planning to start a hospital or just started a hospital. So basically, the purchase department, the text is there, but a purchase department is quite vital to making sure that your day-to-day operations happen and you run your hospital profitability. Daily operations means patient care, and that's pretty critical. Profitability, because you want to make sure whatever you buy is cost effective. At the same time, you want the quality, maintain the quality of your products, whatever you're consuming. And what does the purchase department do? And this pretty much breaks it down. So they identify what is required for the running of the hospital. They look for reliable suppliers. They go into price negotiations. Then they make sure delivery is available on time that they needed. Then they establish order quantity. The previous speaker actually was talking about inventory, and I think this ties into that. And there's something called economic order quantity, because if you order too less, operating costs are too high, delivery charges go up. If you order too much, you've got dead stock. So economic order quantity. They also, in terms of if it's a large purchase or larger organizations, they award tenders and contracts. Government, you see it all the time from government departments where they award tenders, but even private organizations can do that, and they coordinate delivery against storage capacity. Suddenly, just because you're getting a deal on, say, IV fluids, and you order a lorry load, but what is the point if you don't have a place to store it under the ideal conditions? Of course, they have to ensure the quality control is there, and they have to manage budgets and ensure that payments go in a timely manner to the suppliers. So sometimes the accounts department might not give priority on payment. They have to make sure that payments are done at the right time. Purchase department actually wears two different hats. There's a strategic role and an operational role. So let me go a little bit in detail on both. So strategy, like anything else, is like a long-term plan. So they're looking at what is the current needs of the hospital, what is the future needs of the hospital, so that they can anticipate and be ready for the hospital's growth. They can also anticipate, like the previous speaker was saying, that dengue seasons are coming. We need to be ready for that, have enough linen, have enough medicines, or they know seasonal variations when they say, okay, this is exam time and inpatients are going to come down, or in the case of Cloud9, this is an inauspicious month for deliveries and our IP is going to come down. So they can plan accordingly and save money. They also set their policies and procedures. What are the payment terms? What are the rules? What are the kind of vendors we're looking for, etc. And the main objective is to source goods, as I said in the last line, as economically as possible, while ensuring the lowest risk to business. That means just because it's cheap, they can't buy something that is quality compromised because it's a risk to the business. Now, coming to the operational role of the purchase department. This is typically the daily day-to-day activities. It's a short-term transactional role wherein they buy based on the policies, they keep buying it every day, payments, etc. And they're more concerned in making sure that supplies, the smooth running of the hospital is going on. They don't want concerned suddenly calling and shouting at them, or department head saying, I've got a hernia surgery and where's my mesh? And they can't say, sir, the supplier said it'll take 1 week. So that is the making sure that the smooth running of the hospital on a day-to-day basis goes on. Then moving on, what else do? They do a needs and supply analysis. That is, they work with the different departments in the hospital, look at what are the current needs. So there's a little more in depth as to what they do, and then try to anticipate what is needed. And they also look at the supplier, see if they've got the right supplier, right price point, alternative suppliers. And purchase department is involved not just in day-to-day activities, but even in equipment purchase. So if you want to buy a new patient monitor, a new X-ray, they can be involved in seeing what are the alternatives, what are the options, getting recommendations, etc. Then based on that, they can avoid supplier contracts. They will look at each supplier's the cost and reputation. So it can't be just cost. You have to look at the reputation of the supplier in terms of equipment. Will they support you after sales? How reliable are they? If it's, for example, manufacturer, what is the production capacity? And you might think production capacity is only for manufacturing companies, organizations. No, even hospitals, for example, someone's a gauze supplier and we consume a lot of gauze. So what is the production capacity of the mill that is supplying you gauze? And what is the delivery schedules, etc.? And what is the technology they're using? Are they using the latest technology that is relevant to us, etc.? Then finding the right price, the right goods at the right price is quite a complex. That's why we have a purchase department and people are qualified in it. And sometimes they use a competitive tender, just like government departments. I said private organizations can also do that. They also can issue a request for proposal. For example, in our hospital, we have an air conditioning consultant. So we've been under a lot of renovation in the last few years because hospital is about 35 years old. And the consultant would come up with an RFP based on our air conditioning requirement for this department, etc. For example, you're sitting in an IVF lab. This is the air conditioning requirement. This is the theater. And it's circulated amongst a few vendors. Based on the RFP, they come out with their quote. Then you make further negotiations. And then you decide on who you're going to award the tender to, or the contract to rather. And in large organizations, they want to make sure that the supplier is reliable, is not going to go bankrupt. So they might ask for their financial statements, references, credit report, basically doing a due diligence, making sure that suddenly the supplier is not going to leave them high and dry. So an essential role of the purchase department is to not only select the supplier, but maintain the relationship with suppliers, multiple suppliers. And if you have a close cooperation with these suppliers, that also gives you a competitive edge, because these suppliers will tell you about what's coming up new in the market, which you might not know, or they will also tell you about shortages coming up, saying, you know what, there's a shortage of, to my early example, gauze, or in today's current scenario, COVID, there's a shortage of oxygen. It started coming up, although the government is denying it. So your supplier say, you're going to go low on oxygen, maybe you want to retop up your liquid oxygen plant, etc. So this helps you stay ahead of your competition. At the operational level, we're talking about inventory control, and you want to make sure that you have the right product in stock at the right time. Toyota is famous for the just-in-time manufacturing. So you try to run a lean operation. There's something called ABC analysis in the stock. You look at which is fast-moving, which is slow-moving. I'm skimming over without going in too much detail because there's a lot of area to be covered and time is limited. But you're trying to get the stock just when you need it. But at the same time, you shouldn't run into a situation where you don't have it and it's too late. For example, it's not like manufacturing where you can stop the process and start tomorrow. Even in manufacturing, it's difficult. But it's not that you can stop the surgery halfway and say we'll continue tomorrow because we don't have an implant. So like I said, running out of stock of a critical item could result in the death of a patient in extreme cases. And I'm sure we all know that. Does that mean we buy extra and keep it in stock? No, because overstocking means you've got dead inventory, you're paying for it. There's a cost to it. There's a holding cost. And you also need storage space. Those who already run hospitals know that every inch, every nook and corner is valuable because there's just so much to store that if I can reduce my storeroom size, something else could be put up that could be used for something else. Usually all this is done using software, inventory management software, purchase software. And these softwares automatically trigger based on a reorder level. So you say this is the minimum quantity this should go to before it is reordered. For example, typically used a lot in pharmacies, but it can be used in the hospital stores. So you say, at any given time, I want 10 of this item. But once it reaches 10, order 50 so that the stock goes up to 60. So all this means that you have a well-stocked store that is guaranteed to supply you when needed, and the purchase department, rather than focusing on purchasing, what is the stock, because the software is taking care of it, they can look at the quality, check the items, and check the invoices for accuracy, and make sure they come on time. Quality is especially very important in our healthcare industry. Just because someone's giving a cheaper implant, you can't use that, and tomorrow it breaks. Obviously, there are a lot of liability issues, but even more than that, there's a moral obligation also. So you want to get the best you can for the patient at the most affordable price. So they need to continuously inspect the quality, make sure there's no substitution by the vendor. Tomorrow he can't supply something saying it's the same thing without having validated it. And if you don't do that, the vendor is automatically going to go complacent and give whatever he wants. The other thing is also not just quality control, but they have to analyze, see how is the supplier doing. Are the products being delivered on time? Are we using too many suppliers for a product? Suppose our quantity is just less, consolidated with 1 or 2 suppliers so that we can give them better volumes and better discounts. What is the availability with the supplier? If a supplier is irregular, maybe we should drop him. What are the lead times from the time we order? If X is giving it cheaper, but it takes a month to supply, whereas Y may be slightly more expensive, but he has ready stock, he's able to supply it to you in 2 days' time, then maybe the other person, Y, is better. And are we getting any complaints on the product? Are there any defects on the product? So these all allow the purchase department to assess how well the suppliers are fulfilling what the company needs. Is this what we need, and are they satisfying our needs? And based on this, they go back to the strategic part of planning, saying, coming forward, these are the suppliers we should patronize, and these are suppliers we should probably drop. Now, coming to the staffing of purchase department, even a small hospital, a big hospital, it doesn't matter. You should have a purchase department. Typically what happens is a doctor starts a hospital and then he's burdened with all these mundane stuff doing the day-to-day purchases where he's not unable to concentrate on his clinical work and larger strategy of the hospital. So even a small hospital can have a single person purchase department. A larger hospital would have a purchase manager who has several purchasing officers under him with their domain expertise. And the purchasing manager becomes the coordinator between the different head of the departments, the doctors who need these products, and like a licensing, what is it that they need? Is there any complaints with the product? And convey the information down the line to the purchasing officers who do the actual negotiation, and they have the responsibility of purchasing in time. Certain purchasing officers, for example, the pharmacy purchase officer, he may have a domain expert in pharmaceutical industry saying, okay, these are the medicines, this is what is needed, because it's slightly different from the general stores. I missed a point regarding earlier about overstocking also. Being in the medical industry, a lot of products have expiry dates. So overstocking means you run into the risk of product expiry and wastage. The benefits of having a purchase department is definitely it works to the overall financial benefit of the hospital. A good purchase department can save money. Unlike a revenue generating department, this is in the process of saving you money, and having strategies means there's less chance for deviation and corruption. They're looking at internals. Sometimes they also have to monitor what stock is available within the hospital, because some ward or department might have excess stock and the other department has less. So they can also do internal transfers to make sure that there's no wastage. Transparent procurement processes means that above board, no vendor is patronized just because of other reasons, and prevent any operational shutdowns, which, as I said, can always lead to the death of a patient or morbidity. The purchase department can take advantage, the benefits, other benefits. They know the suppliers, they know what's happening in the market. They have talked to the other colleagues in the industry, And they can take advantage of discounts, bulk purchasing discounts, or something's on offer, get better pricing. So all that leads into your basic bottom line because you're saving money. The other thing is they also validate, make sure that the vendor is reliable. He's not there to take your money and disappear. And they relieve the actual heads of department of this mundane job where they can concentrate on their actual day-to-day work. And it reduces the scope of corruption because by the time any organization, you're worried about the purchase department, people are led to buy whatever they want. They might have a vested interest because they're getting kickbacks or it's their relative, etc. So you centralize in the department and you monitor that department to make sure that that department doesn't turn corrupt also. I'd like to mention something about group purchasing organizations. This is quite common in the US, and I mean, I've seen some talk about this in India, but I still haven't seen any traction on this. So this is a great benefit to hospitals. A couple of hospitals, competing hospitals, also combine together and create a GPO. And this GPO basically aggregates their volume, and naturally, with more volume, they get better prices. Something I think is overdue for India. It relieves smaller hospitals of having to have an extensive purchase department. For example, one of the hospitals I used to be in the US, they were part of a GPO, and every year the GPO would publish a booklet, and you could say, okay, I want a stent, and you just open the booklet and say, this is the price that they've negotiated for the entire year. You want an RBOT stent, this is the price, you just order, and it's always cheaper than what you'd get directly. And because this group purchasing organization is owned by the hospitals, the GPO is funded by about 2-3% margin on what they purchase, but any profits is given back to the hospital because they're the shareholders in the GPO. The GPO can also not just restrict themselves to medical, but it can be non-medical supplies like printer paper for your laser printer. A quick word about NABH. NABH requires hospitals to constitute a purchase committee that has to meet at least once in 3 months. And the committee has management, accounts, biomedical department, quality managers, and whichever department that's involved in that particular discussion are brought in. And you have to have minutes of the meeting and say this is the products that's been decided, etc. So having a purchase committee is part of an NABH requirement, and it's one step from there to having a purchase department. In conclusion, I'd like to leave this slide for you to show what it is that purchase department does, and that concludes my presentation.
Thank you, Dr. Suresh, for the wonderful presentation. And we are going to take up some questions for all the 3 talks right now. So to start with the first talk about the biomedical management, and question to you, Mr. Nitin.
Yes, sir.
Nitin, you told, you mentioned about all these biomedical waste has to be treated within 48 hours. And can you please elaborate on that?
So what basically it means is any waste that gets generated in a hospital can't just stay in the hospital for about 48 hours. It has to be segregated, collected, and sent out of the hospital, and it has to reach its destination where it goes into its own treatment process. Now, that could be in the form of incineration, it could be in the form of disposing, and if it's a general waste, it could probably go into a landfill. So there can't be anything which is lying around inside the hospital for a long time. And typically it's basically to do with risk of infection. Now, the risk of infection, as much as we look at it from a patient point of view, we also need to be aware of the fact that every hospital has hundreds of employees working in it. It's not just about patients being exposed to hospital infection, but it's our own staff who could get infected. So it's for the safety of everyone that we need to follow this process, and very, very strictly.
That's very, very interesting topic that you have broached on. And actually, I have been unaware of this. Actually, it has to be treated within 48 hours. And in your opinion, what do you think? So how are the majority of the hospitals following this?
So yes, pretty much Most of the hospitals are following it. I can't think of any hospital of decent size which is not into it. Now, not only this, I mean, if we look at compliance to norms in a larger context, of course, this is a biomedical waste management in a smaller context. But if you look at compliance to norms as a whole, and healthcare industry has moved in this direction tremendously, I think, over the last 7, 8 years. And this is across the country. It's not to do with the healthcare institutions or establishments in Karnataka alone, but it's across the country that I have seen compliance to norms across the board has improved phenomenally. Now, there are multiple reasons for it. One is the general appreciation towards getting there. That's there. Second, we have also most of the healthcare institutions, even of reasonable size or small size ones, are extremely cautious about the image that they project. About the kind of about the kind of feedback that people talk about them, in social media or in any other public forum. So people are very cautious about that image management. So that is another factor that's prompted it. Then there's the other aspect of a lot of private equities and funds coming and investing, who have brought in professional management, who are forcing compliance, because in any non-compliance at the institution level tends to have a substantial impact on these funds and private equities, who definitely don't want to be seen to be on the wrong side of the law. So they are ensuring a different level of compliance. So by and large, if you look at it, compliance to norms as has prevailed phenomenally, and a lot of healthcare organizations are moving in this. And many a times it is also the sheer brute force. If you look at PCP entity, for example, if you don't comply, you will cease to exist as a healthcare institution. It's the brute force of the law that is working in that in such instances. So it's I think overall we are getting there. We are getting better as an industry, and definitely we there is some distance to go, but we are in that direction.
Yeah, here we are talking about definitely the hospitals. Just to, is there any recommendation for the clinics? Because 48 hours disposal in clinic can be challenging, especially in a smaller clinic. Are you know of any timelines for the clinic to dispose of this waste management?
Specific to clinics, I don't think the turnaround time of 48 hours applies. But even in the context of a clinic, the medical waste can't still be hanging around. I mean, just to give you an example, this morning I had taken my daughter for her treatment for her braces to a dentist, and that entire clinic is about 150 square feet of space. Now, if the doctor over there is not, ensuring that whatever gets generated over there goes off, there is literally absolutely no place for someone else to go and sit over there.
Can I
I'm
request you
talking
to
of.
mute your this thing? Somebody
Please
else is
speak.
having a background noise. Can you please all of you mute your microphone except for the speaker? Thank you.
So even in a clinic context, if you look at it, the need for us to dispose waste is even more amplified if we were to, if I were to think of it. And to be able to help these people, I think there are agencies. There are agencies who come and who pick up the stuff. So it's about, it's just that we have to search and find out who these people are. And in Bangalore, I know there is Sembranki and there are a couple of other people who are around. And I'm sure we will have similar such people in every single city with whom these people can partner and then get this thing done.
Mr. Nitin, just to get an idea about how much waste has been generated as a result of this COVID, do we have any comparison data before COVID and now during COVID, and how much is the hospital waste being generated, biomedical waste?
So I'm sorry, Dr. Srinath, I don't have any data on that because our dealing with COVID cases is very few and far, and we don't deal with it actively. But I would tend to believe that the quantum has increased substantially, and I have so the while I don't know the weight I mean, in terms of what is the actual data, the quantum has definitely increased exponentially because I talked to some of my peer in the other hospitals, and this whole PPE usage, a lot of other consumables which are disposed of after one usage. Patients who are impacted by COVID are provided food in a particular, plastic disposable containers, which are disposed immediately after usage. So I would only think that the quantum has increased exponentially.
Yeah, that's true. It's a challenging times, and for all over the world as well as for the environment. I think
Yeah.
yeah, it's very very important. The this topic actually. Thank you so much. Thank you so much. And next we'll more to a couple of questions with regards to the housekeeping. And Dr. Pawan, are you there? Dr.
Yes, sir,
Pawan.
I'm there. Yeah.
Dr. Pawan, it must be very challenging, especially during these times, to keep up the morale of the housekeeping because they are the people who really make sure that we are all safe, right?
Right.
So, how do you ensure to keep up the morale and so that many of them may be scared about working during these times, picking up these waste and making sure that they must be afraid of about them getting COVID themselves, right? So how do you keep up the morale and make sure that there are no absentees and these healthcare professionals do not actually get infected?
Right. So I think, Dr. Srinath, what is more important? I think this is a bigger question than just pertaining to housekeeping. This is pertaining to all the staff in a hospital.
Yeah,
How do you keep them working on the floor? They all
exactly.
are scared for themselves, right?
Mhm.
And I must, kind of pay my due regards to Dr. Kishore on this front, on what the leadership at Cloud9 achieved for the organization in a very short span of time by extending for the staff on ground. So I think a couple of things that we did very quickly as soon as the pandemic hit was we extended unconditional support in all regards to all the staff. I think most of the staff when the pandemic hit were, kind of there was a lockdown across the country and they were facing issues with transportation. Now we not only provided transportation, but the people who were coming from far away, we provided them accommodation. And we took care of their boarding, lodging, food, all expenses.
Mhm.
And then on top of it, we discussed quite a lot and we said, these guys are actually going out of the way. And in this time, they are risking everything. And how do we incentivize them financially or otherwise? And while many organizations were found wanting to take a pay cut for their staff and other things, Cloud9 stepped up and incentivized staff to work in these difficult times. And mostly it was a very harmonious familial environment where people felt that they are being taken care of. People saw that anybody who fell sick, even if that was because the person carried disease from the community most of the times, the organization ensured that they were provided a safe abode in a hotel, treated by a doctor, and if needed, hospitalization at the cost of the organization to indefinite amount. Now, when you extend yourself for the staff like this, the staff also treats you like family.
That's a fantastic. That's a true mark of leadership, and we all know Kishore sir for a long time, and I'm very very glad that you brought up this. And then it is very very important, especially during these times, to take care of the staff. And I think
Right.
Cloud9 has done exceedingly well. Um, I hope all the hospitals are doing their best to keep up the morale and taking care of their staff very well. And
Yes.
this is a very particularly challenging times.
Yes.
And one more question I have for you is, uh, see, there are some uh, uh, actually now government offices and the airports, they are using instead of the chemicals, they are using uh, uh, the organic disinfectants.
Right.
So, what is your experience about using the organic disinfectants?
Sir, I think I would answer this question in two parts. One, during my presentation, I addressed one piece of how do you select a chemical. And I think for hospitals, it is very pertinent that a chemical is selected basis evidence of it being effective.
Mhm.
And that is why we go with a particular set of chemicals.
Okay.
Now, people have started using organic in a hotel or a airport kind of a setting. But the hard evidence of that is yet to come up.
Mhm.
Basis data and studies and mass scale studies of what it has achieved. As hospitals, we are still, shying away from using till we have hard evidence to kind of back up, especially given the kind of work that we do, where there is always a pertinent risk of spread of infection, not only from one patient to another, but also from patients to staff. And we would shy away from, taking any risks at this moment of time, especially. So we heavily rely on bacillocide for terminal cleaning. And whenever we have to kind of completely sterilize an area, we use sodium hypochlorite. So that's been a traditional practice. Hospital and hotel housekeeping have been traditionally different, and that's largely due to hospitals making infection control as an integral outcome of the housekeeping mechanism, while hotels has primarily to do with the other aspects of housekeeping and less on the infection control piece.
Thank you, Dr. Pawan. The next question is for Dr. Suresh.
Thank
Okay.
you.
That is, it must be especially challenging, especially during the beginning of the pandemic for a purchase department. I think world has been caught unaware by this COVID pandemic, and there have been a huge shortage of PPEs, especially in the beginning of the pandemic. And I'm sure you must have faced challenges in the beginning. And how did you overcome that?
Uh, yeah, I did wonder if I should mention about PPs, but like I said, proper purchase department that has strategic thinking should have anticipated it and started identifying suppliers. In our case, except for the first, like you said, initial few days, by then we were able to identify suppliers, and uh, existing suppliers who we had a relationship with were able to supply it without inflating the prices exorbitantly. Because I know some hospitals had to pay a lot of money to get basic, even the masks. Even AAA masks went up in price by even 10 times in the initial panic.
Mhm.
So it all depends, like I said, on how your purchasing department has a relationship with your vendor.
True, true. And there have been reports, like for example, in the beginning, the most of the PPEs used to come from China, and there were a lot of faulty PPEs and also faulty equipments provided from China. If something like that, how does the purchase department will take up the issues, and how do you get it? How do you send it back and get it refunded, especially if it is coming from a different country like China?
Okay, once again, that's where you need to work with a reliable supplier. So if you are importing it directly from China, you're out of luck. That simply you can never, you're never being going to be able to find him, and it's not worth the cost sending it back. Because I know there were some reports of thermometers, IR thermometers, which were giving faulty values, or even SpO2 finger probes, which are giving values. So ideally, you work with, it might be a little bit more expensive, but work with a local distributor who you can hold accountable, or someone who will take responsibility and will not cheat you.
Okay. Okay. Thank you very much. Thank you, Dr. Suresh, for that.
You're welcome.
Prashant, do we have any more questions?
Yeah.
Prashant, are you there?
From my side, no. Um, I think I'll
Prashant?
request Kish. Hello, sir.
Yeah, Prashant, can I ask some questions?
Yes,
Oh,
sir. Yes, sir.
please.
Yes, sir. Yes, sir.
Please, Dr.
Okay. Sorry, today I am not feeling well. That is the reason I'm not so active today. Okay. Okay. I don't know whom to ask this. I think so. Linen, whether to use linen. I think so. In one talk, Nitin or Pawan has told we
Dr.
have to use.
Pawan. Dr.
Yeah,
Pawan.
Nitin,
Yeah.
they were telling at least we should have 3 to 4 extra linen. But I think so. Now I have seen 3, 4, 5 hospital. Not only ICUs, for the room itself, they are giving and writing to the patient's attender disposable linen in one kit. It is around 650 rupees. 6 pillow covers will come and 6 bed sheet will come. Even if they will urinate, it won't go down. It's like act like an this thing. It is very small, thin. It is because every day sister will come and change that bed sheet as well as so it will come for 5 days. It will 5 days, one kit will come. So when we asked how, where, and I saw it in what is it, Dubai exhibition, and I have the number where they will supply it in India, Bombay. They are taking it. Okay, and I don't know why it has not become famous. I probably Corona it has not become famous or something. Is it better? Because we are writing and giving to the patients unnecessary bed sheet. Once again, one patient clean, some stain will be there and some stink will be there. Rainy season it won't dry, some fungus stink might. And even though hotels or whatever we do it, you know that once we dry it, clean it, and even fragrance also is there, it will only iron and fold it and give us. It will all cost per bed sheet minimum at least 18 to 16 rupees, or I don't know how much in Bangalore. What everything I need, everybody has to answer for this question. Even Kishore, sir, if you know something, you also can answer regarding Suresh. Waiting for from you also one answer. Anybody can start, please.
Okay, since I touched this topic of linen, Pawan here, I touched this topic of linen in my presentation, so I'll start. I as an idea, I really like this idea. It frees up a lot of hospital bandwidth and cost per se in management and addressing the need of linen and keeping an inventory of linen in house per se. Uh, However, I would really love to see the product and then kind of vet for or against it, depending upon how it is. From the idea perspective of having a disposable linen in these times, it sounds good. But I think if it is a disposable linen for sure, will it not be a wastage of lot of resources? So if we take a view with regards to what are we doing to our mother nature or what are we doing to this planet, then there could be views for or against. However, from a hospital operator point of view, I really love this idea.
No. It is a biodegradable.
Okay.
Biodegradable. At present in India, people are using. Even
Right.
in Veerapareddy Hospital, they are using pillow and this thing. It is 65 rupees only. It will come 2 bed sheets and 2 pillow. It is coming. People are using it. It is nice. It is biodegradable. And
Okay. I would love to see and kind of take a view on this because
So,
from a hospital operator point of view, it's really a great idea.
Zinagar, if I could add, I actually
Suresh,
have, sure. I know a hospital in Coimbatore, Friends Hospital, where I think they're about 7 years old now. And from day one, they've been using disposable alternatives for linen, pillow covers, and things. Because he said, my cost of savings on setting up a laundry, manpower, water, detergent, is this works out to be cheaper, if not equal cost. So it is doable. And like just mentioned, please do share this number of this person because I would also be interested.
so Nitin
waiting
here
for you.
from Cloud9, just to kind of add to this. So there are a couple of vendors in Bangalore, and I'm in the process of sourcing this and then doing a pilot around it. So we are current right now as we speak, we are negotiating the cost of this one. I do agree that the price is not so high, and it kind of takes over the headache of keeping the linen clean, the entire logistics of washing and trying to keep it white and clean so that there are no customer complaints and things like that. So this takes over that headache.
When it reaches India, Nitin, that product, it is 650 rupees. When it reaches in India, it will be 900 rupees. But whatever the MRP you want, you can take, because pharmacy will be also beneficiary. At the same time, whatever we earn from that, we can give to housekeeping also. And one more thing, it is more hygienic.
No, I
More
agree. I totally agree. In fact, the alternative that I have costs somewhere around 300 to 400 rupees for a bed sheet and pillow cover set.
bedspread. Bedsheet, they don't have till now.
Yeah, I mean, yeah, bedspread and pillow cover set. Yeah.
Bedspread. Okay. And one more thing, please.
Talking about in Coimbatore, the vendor is from Bangalore. They've been getting it from Bangalore.
Yes. He is there in Bangalore. Correct. And one more thing, sorry. Okay. Everybody will use the, what is it? Chemical. Nitin or Pawan were asking this question. I don't know. You were telling in our hospital, Basilide and all, it is 900 rupees or something like that for 500, 400 ml. Sisters might not know that. So they are putting, instead of 10 ml for 1000 liter, 10 liter water, 10 ml, 10 liter of water, they are using, just pour it. So you are telling about diluter. I don't know what you mean by the diluter, how to get it. Please, can you just tell me where it is available? Because 10 ml Basilide or, Basilide, this thing spray will come. Basilide solution will come 400 ml. It is 900 rupees on the MRP. I don't know how much we will get in wholesale. And the number one is, one more thing, one more big solution for the detergent floor cleaning. For floor cleaning, around 20 liter, 2 solutions can will come. You people should tell me what you mean by diluter, mixer, where it is available.
Right. So, sir, typically, Tasky is the company that provides you with a diluter along with the chemicals. So, if you allow me, I could just show you a pictographic representation of what it actually looks like.
Please.
So this is how it looks like.
Another half an hour, it's all yours here, because we are there. See, previously 190. After slowly classes, it has stick to weekdays and all. It will stick around 60 people who are core people who wants to open the hospital.
Right. So I think this is what it looks like. So these are the various chemicals which is provided by Tasky, and you just fill it in for the chemical that you need a dilution, and there is a water supply connected, and you can preset the diluter at say 5%, and then it will make sure that for every 19 ml of water which is added, there is 1 ml of fluid which is going in, 1 ml of chemical which is going in, and it fully comes in.
Housekeeping will come and just open the tap and take and go and clean it.
Yes.
It is available in Cloud9. Can we see?
So it is. So we asked Tasky to kind of install it in one of our hospitals and give a demo and train our staff on this. If you want, we can kind of connect you to this vendor to provide.
Please,
give a
we will take it from Kishore sir. Please, if it is there, you tell us. Okay, Suresh, you want to add anything?
No, I have nothing to add right now for that.
No, because my my NICU staff are using so much, wasting, and I am feeling, because I started seeing since 1 year, I am just burning my stomach, because hospital owner is, they are giving us food, but sisters are pouring so much, but I don't have control. Slowly, if now we are opening the hospital, same thing will follow.
Dinagar, it's not just a NICU. Your maids at home are doing the same thing. More detergent means cleaner. More oil means tastier.
I should tell my wife also.
Dinagar.
Sir.
Yeah, I'm Kishore here.
Sir.
The tips to, I know you're starting a hospital and you're asking all these questions, but what you have to understand is when you start the hospital, the first 3-4 years, you need to have all the headaches. And as you grow bigger and better, and it's important to have the protocols from day one. But once you start growing, You will
Sir.
have people whom you can delegate the service, and you have to trust them. And if you trust them and delegate the services, half of your headache will go. If you keep worrying about it, as you rightly said, your stomach ulcers will happen. You will never be able to relax. So sometimes you have to close, your eyes to small wastage like that. I mean, the best example is like Nitin and Dr. Pawan. Now we close our eyes, whatever they do, because we trust them so much, and they have become really, for all practical purposes, they'll be CEOs of big hospitals in the near future because they have attained such leadership. And you have to start delegating once you stabilize a few months or a year or two into the things. Now, the second thing is what I have to tell you is 15 years ago, there was no information available on anything. But things were also not available in India. For example, we brought cleaning equipments called Karcher to India from Australia because there were no cleaning equipments properly available in Bangalore even at that time. Now you have most of the things available. And there is a medical magazine called Medical Buyer, for example. It gives you all the vendors, all the details of most of the equipments available, and you can subscribe to that, and it's not expensive magazine. In fact, if you say you're a doctor, you get it even free. The third thing which I wanted to say is Ganesh was talking about GPOs in the American side. See, the consumables are a big cash flow burden for you. But what happens is, as Suresh was telling about GPO, FANA has recently started this group ordering. That's why I wanted Vidyanand to talk about it. Unfortunately, Vidyanand had a personal emergency and he couldn't be there. In fact, what FANA has done, FANA stands for Private Hospitals and Nursing Homes Association. And what they have done in Bangalore is they're taking orders from all the small nursing homes and ordering bulk. Now, that is for a smaller nursing home. If you're a very big hospital, in fact, what big hospitals do in the US is they ask the consumables from the companies to be delivered on the day of the surgery or the day of the consumption so that they get 2 weeks from that to play. Because normally, most companies allow you to pay for the consumables after 2 or 3 weeks, or you bargain well, you get 6 weeks also. So your cash flow will be very well controlled, and you can basically consume things and pay 6 weeks later. So your cash flow will be protected. I think Suresh has addressed that issue very well. But these are all the learnings which you learn over a period of weeks. And when you order equipments, one of the other things which probably you need to learn is AMC and CMC. Because the equipment when you buy, you need to make sure that you either have a contract with the AMC or a CMC. AMC is annual maintenance contract. CMC is complete maintenance contract, which includes parts and labor and everything. See, that if you don't include and if you buy equipment, you can be in big trouble if a machine breaks down, especially if you're in Kolar and people have to come from Bombay or Bangalore. They'll charge you a bomb to come and serve in Kolar. So these are all the things which you need to look at. And certainly, I think before I close, I have to thank all the three speakers for a fantastic presentation. Especially Nitin's presentation was very crisp and clear about biomedical waste. Dr. Pawan, being a doctor himself, anesthetist and a regional director, he has educated us about nuisances of housekeeping, which is a big challenge. And you will have this challenge when you start, and you can't get stomach ulcers for that, because what happens is you train somebody to work in the OT, and if that person is good, the next hospital will come and hire them for 100 rupees more salary and they disappear. So you will have all these sort of nuisances and you will have to cope with that. With that, I think I'll hand over back to you.
Sir, well, very good question. I think so. Nitin or Pawan was telling, we will weigh the biomedical wastage, then we will dispose it. Actually, that vendors who will come, because Bangalore, Kolar or somewhere, some people will come and take that biomedical waste. They will charge according to the beds, how many beds you have. So is there anything like a weightage you people they are charging, or according to the beds they will charge? Because we have to do the contract with them 1 year, 2 year, 3 year according to the beds. How they are charging?
Nitin can answer that. Nitin, go for it.
Dr. Dinakar, sorry, I missed that last part.
No, his question was, Nitin, Maridi or whatever biomedical waste, they sign a contract with the hospital based on the number of beds.
Yeah.
So what is the reason for weighing the biomedical waste when the contract is for the number of beds? That was his question, if I understood correctly.
So doctor, they generally expect a certain load, a range of a load to be generated as part of the medical waste. Like Dr. Srinath was saying, in situations like we are dealing with right now, where from 500 grams is if the normal quantity was there, we have increased it to almost 3 or 4 fold. The load on them in as far as transportation of that waste is concerned is going up. So they will charge us back in case of such situations. So that's why if we are within a certain range that they had estimated during the contract stage, which is a function of the number of beds, then they are okay. Some variations here or there, they're not going to overcharge us. But when the range goes beyond and the weight of the waste being discarded increases exponentially, they're going to come back and then charge us back.
If I can tell you the reasons, Dinakar, why it is in the past people have been caught offended because you may not do that. So some nursing homes have registered and then they have collected the waste from 3 nursing homes and given to them so that they pay 1 nursing home charge, but 3 nursing homes are taking part. That is the reason now they know what is expected for a particular nursing home and what is the weightage like that. I hope you understood what I meant.
No, I got it, sir. No, very good. And one more thing, I think so, Nitin or Pawan, and even this question I want, Suresh, if you are there, you should also answer. How to appoint housekeeping staff? Because everywhere, all the hospitals, they are giving outsourcing, number one. Number second question is, why they are outsourcing? My second question is, they are giving to the local people, but some hospitals they are not giving to the local people. This is my second question. Third question, but since 2-3 years I went to many hotels, and I went to the where they will work in the kitchen and housekeeping people, and I asked, they are getting all Northeast people, they are keeping them in the hostel, they are training them Northeast people, students like a nursing students, they are giving them only, to tell you very frankly, 8,000 rupees, 6,000 rupees with hostel with 3-time food. Then after 1 year they are giving them 12,000 rupees. They are appointing them in the many different hotels as an housekeeping staff. First 1 year is a training, but it's not a training means it's not a certificate course or anything. Just they are getting it. So I requested them. So can they come to our hospital after their training or something?
Dr. Dinakar, let me take that. I'll try to answer a few things and then probably I'll have Dr. Pawan also add on to it. First point with regards to is the outsourcing versus having our own manpower on housekeeping. See, by and large, if you look at healthcare as an industry, most of the players are now moving to the phase or to the zone where everyone wants to focus on core. And anything that is not core, you would rather find some other vendor, partner, some other firm to do it. Now, what is core to a healthcare organization? Core to a healthcare organization is clinical care. Now, what is the best investment, best area to invest in terms of time, money, effort, as management in a healthcare institution? It's in terms of, what do we do to improve the quality of care? What do we do to improve the customer experience? And anything else, I don't think is something that needs time, honestly. So by and large, most of the people are moving towards a vendor contract. Second is also the fact that vendors are held on to a certain SLAs, and when they fail on their SLAs, the commercial implications are very, very tight. So you would be benefited from these kind of SLAs. Third, by having a company do a specialized service like G4S for security, or dusters for housekeeping, these people have accrued their experience having worked in multiple organizations in different environments. So in a way, we would also be better served by some of these people because of the weight of their experience. That is the other thing. Now, the other point you said was with regards to people coming in from Northeast. I mean, without getting into any regional aspect of it, one thing I would state is I'm aware that the hospitality industry, has a lot of workarounds, or they do a lot of stuff which are quite eye-popping at times. It includes even the number of hours that most of the staff put in. But considering the amount of glare, and considering the amount of focus and micro focus that governments put on the healthcare industry, and also coupled with the fact that we are always under a microscope, I don't think we should ever think of even violating norms by even an inch, and it should never come in. By and large, regardless of where we employ, direct employment or contract, we are governed by minimum wages, and these minimum wages act vary from state to state. And I don't know of any brand healthcare establishment out there which actually wants to take these guidelines on. And any violation of these things would actually end up becoming extremely negative on the brand and on the institution, even amounting to shutdown. So we can't really risk as healthcare establishments deviating from some of these things. I try to speak a lot in terms of all the range of points. Dr. Pawan, in case you had to add.
No, I think Nitin, you have fairly well captured the intent of outsourcing. That is primarily that organizations like Duster come with a certain expertise. While a hospital has an expertise in a clinical area, housekeeping is not our expertise, and we essentially tend to outsource this to people who are experts. And so far as compliances are concerned, the labor compliances are something that we do not want to stretch our HR at managing them uh, internally. And that is why we get it outsourced through a vendor who manages their labor compliances. And by and large, all the hospital groups with time have become more and more sensitive to compliance needs. It could be because of increased government scrutiny, increased focus on getting NABH accreditation, uh, or increased PE investment, which is mandating compliances. So by and large, the focus towards being very compliant has increased, and it's 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 not worth it, to kind of save some pennies in this regard by compromising on compliances like hospitality industry would be doing. Furthermore, I think the core work of hospitality industries dwells in this domain of food and catering, housekeeping services, while a hospital's core is more into clinical area and not into this. So while hospitality industry could easily insource and make it a core competency of them, for hospital, it's better off outsourcing than insourcing.
Dinakar, it's Kishore here.
Yeah, sir.
Yeah. One practical point, see, I think Nitin and Dr. Pawan have highlighted really, really well. What you have to understand is, see, for housekeeping, you're competing with the hotel industry and software industry. So it's very, very difficult to match it most of the time. What you have to understand is 90% of your housekeeping needs are general housekeeping. Only 5 or 10% of your housekeeping is medically trained. For example, a person who attends OT and disposes of the blood products, or labor room disposes of blood products, they need to be specially trained in the handling of the blood products. So if you make sure that consistency of those housekeeping stays and you don't lose them, Rest are all cleaning the floor, cleaning the room. You don't care whether it is A does that today, B does that tomorrow, C does, because ultimately your time and energy is housekeeping for the OT and the labor room, which is prime concern, because that housekeeping needs is totally different from a hotel industry. So if you look after that needs, that person on that shift very well, then half of your headache will be solved. That is just a practical tip which you may or may not know whether when you outsource it.
Yeah, sir, why I asked this question is, Dr. Dhananjay, are you there? Dr. Dhananjay? Prashant Gowda? Prashant? Okay, sir.
Yes, sir.
Hello.
Yes, sir. Yes, sir. Yes, sir.
Have you invited Dhananjay Sarji?
Yes, sir. Yes, sir. Yes, sir.
He's supposed to be the moderator. That is the reason, because he's in the periphery. Because
Yes,
in the
sir.
periphery, Kishore sir, in the periphery, what happens? Usually they will gang up. They will ask for the more things. They won't allow anybody to come inside. And it has happened in the periphery, rural areas. That is the reason. City, it's okay, sir. Suresh, what is your impression?
City, it's
Prashant
even
Gowda, call Dhananjay Sarji also on the line.
city, it's
Suresh?
even worse.
Sorry, Dr. Kishore, go ahead.
Sorry,
No,
sir.
I think Dinakar has got this impression that cities are much easier. City, it's much worse. Brand A takes somebody very well, brand B takes them off. It's happened to us. I'm sure Nitin can vouch for it. And brand C will take them from brand B. So it's a mouse and cat game. And we have had that problems in Bangalore. So don't think that it doesn't happen in cities and we are insulated. It happens everywhere. You have to be prepared, both mentally, physically, everything. So I don't underestimate urban problem compared to rural problem. Everywhere in India, it is the same problem.
So it is
coming from a
yeah, Suresh, please tell me.
Yeah, so Tier 2 city here, Salem. Till recently, about 1.5 years ago, we were having in-house housekeeping, and then finally, because there was no outsourcing partner available in Salem that was reliable, but finally, one company that was operating in Coimbatore started operations in Salem, and they started with us. And we've always faced a shortage of housekeeping staff. It's not that we don't want to employ local people; it's just that, especially in the south and Tamil Nadu, education levels have gone up, and getting people into the housekeeping sector is becoming more and more challenging. That is one thing. The other thing is, when we have a outsourced vendor, we just tell them that we need 10 people per shift or whatever, and it is their responsibility to have replacements, day offs, etc. Because we are dealing in terms of man days or man shift, how we want to do it. Another point I wanted to make is, even if you are outsourcing it, you are legally liable to make sure that your contractor is paying PF, ESI, all statutory dues. You can't just say I gave it as a contract and it's not my responsibility. It is your responsibility to check their books. They have to show receipts and proof that they're submitting all. I mean, they're taking care of all statutory requirements. So that's something that you have to be aware of.
Yeah, sir, this is directly to Dr. Kishore Kumar, sir. Because there is only 2 questions. After that, Prashant Chinta, technologically, he is having question for Suresh and Kishore and all the people. There is only now last but 1 question. Do you think overstocking, you are telling? Yes. I have seen in overstocking near Mandya, one hospital. They kept 8 bins, steel bins. It is all rusted. When I have gone there to see, just to show me your stock, then I inquired, what is this? What when I opened, then only they came to know that all the bins were, it is rusted. So do you think, I know that Suresh will be having one software, what is there, where it is there, everything. So I think so, if software is there in the purchasing department, pharmacy, what all the things medically we have purchased, surgical equipments we purchased, why it is not moving, housekeeping, what all the things we have purchased. Housekeeping, Rubbermaid is the company, USA, it is very famous and it is last long. Why people are not buying that housekeeping Rubbermaid? And stationery, I have seen in some hospital, I don't want to tell the hospital name, and people are not bringing the pen, boss. People are not bringing the pen. They are telling, I am coming here. Let the hospital give pen. And pencil and sharpener hospital has to provide. It is a pathetic situation of when I worked for a long time, I didn't feel it. Now I am feeling it. Pen, pens, they're using it. They're asking for the pen, pencil, rubber. So how you are going to purchase all these things? Are you people are also purchasing stationery? Are you people are pharmacy, medical or surgical, housekeeping? How you people are purchasing? Are you people are having indent software, where it has gone, which nurse has taken, how long it will come? How you are managing in your hospital, Suresh and Dr. Kishore, sir?
Dr. Kishore, you first, please.
Sir, Kishore, sir, don't feel bad. It is my genuine, genuine things.
No, I agree. This is a problem which will happen. See, you have to accept that there will be some amount of people, but not everybody will be like that. And you have to handle that. And when you're a small hospital, you will have problem in tracking it. Once you're a bigger hospital, you will have other problems. But tracking and tracing is one important point which you have to do. And sometimes you have to accept that there will be some amount of wastage and some amount of people who will be like that. You can't generalize that statement, because what happens is, just to give you an example.
I think Dr. Kishore got disconnected, so I'll jump in till he comes back.
Yeah.
You talk. Dr. Kishore had mentioned that you have suppliers who can give you time for the surgery.
Hello. Sorry, there was a power failure.
Yeah, my mic stuck there. It is dividing into 3 compartments. One is for pharmacy, another is pharmacy divided into medical. Purchasing department is purchasing it. How you can track in the software, right? Why can't we track it till it rusts? Housekeeping also, Rubbermaid is more better. USA band longevity is there. Why we have to go for 5 rupees broomstick? It won't come for 1 week. Why these stingy things are going on? Stationery also, why it is going on like this? I think Sir Kishore Kumar got stuck.
No, I'm back. Can you hear me?
Sir, please, sir. Sir, 3 questions. Housekeeping, stationery, in pharmacy, medical and surgical.
Yeah. See, your question is a genuine one, Dinakar, but what you have to understand is these are all human behavior and human nature, which is going to be arising time and again. And you can't be having an answer to all the problems. See, when you're a small organization, you'll have different problems. When you're a larger organization, you'll have different problems. Just to give you an example, when we started 15 years ago, we had a theater nurse who used to bill 2 catgut sutures for every catgut suture which a surgeon used. And at the end of the month, we were wondering how come we are consuming so many catguts. And she used to go and sell the balanced catguts into one of the neighboring nursing homes for half rate than what we purchased. So it took us nearly 3 months to figure out that this was happening. Then we thought we have figured out and we have cut all the things. Then we found out there was a nurse who was not giving morphine or pethidine whenever the patient was given. It was just documented, but it was shown as being taken and consumed and signed by people. But then, this was happening under our nose for about 2 months before we realized that morphine and pethidine is not being used. So these things do happen, and it's a human behavior and human nature which you have to correct. And it will happen time to time. You're talking about a pen and pencil and eraser, but I'm talking about the serious things much higher than that. And doesn't matter how much you track and trace, though we had a track and trace for all the catgut sutures, all the morphine and pethidine, it still happens. That's why what I'm trying to say is you can't be tracking and tracing for everybody. You have to have trust. You have to have eyes everywhere. You have to have honest people reporting to you, and you know, take action as and when it happens. That's all I can say. Nitin and Pawan, if you have any other suggestions, please do jump in. Suresh, you are going to talk. Sorry, you can go ahead.
Thank you, Dr. Kishore. Word of consolation, your hospital is not the only hospital that's gone through this cat issue. I think every hospital has gone through it at one time or the other. But like you were mentioning, a very important point.
Sorry, why I mentioned catgut is Dinakar was asking about pencil, pen, and rubber and all.
It's coming to that. It's coming to that. So, Dinakar, forget
Sir,
about
don't
pens and
make
pens.
me cheaper. Don't, sorry, Suresh. I am seeing one big institution. People are telling, sir, I am a nurse. Today I didn't come pencil. Hospital supposed to pay. I am writing in the case sheet. I am fed up of the pencil, paper, irritation has come to my brain. Now I am starting hospital. Now I am feeling how I should handle. That is the BP. Sorry.
In the employment contract, please specify that you have to bring your own pens and pencils.
It is shame for us.
No, but like Dr. Kishore was saying, pen and pencil are small fry. Look at the more important things. Even in the pharmacy, where we have, I'm sure everyone who's using software tracking, we concentrate on the more expensive items, antibiotics, etc., where we do cycle counting. We're not really concerned about this Avil and Dolo 650 paracetamol, which there is a shortage of a few tablets here and there. It could be pilferage, it could be breakage, but we're looking at the more expensive. That's part of the ABC analysis also. But if you're keeping track of your more expensive items, like again, there's something called the 80-20 rule. 80% of your most expensive products constitute only 20%. 80% value is 20% of the products. Or the other way, 20% of your products constitute 80% of the value. So if you can keep track of those 20% and not really bother about the remaining 80 that closely, I'm not saying you should leave it for free, that closely, then you will be having less BP. Otherwise, you will have to start with antihypertensives right from day one. Coming to tracking, like you're saying, buckets and all these things, a purchase department can play a role, because they say, do we need so many items? Do we need to issue it? And try to go in, for example, even you were saying that cleaning supplies, they should question if they're being asked more supplies week on week. They should question when they're issuing, saying, why do you want, last week you took 1 liter, this week why do you want 2 liters? So all that is part of the purchase department. And then the purchase committee also looks at the costings, accounts, whoever's saying that, in last quarter we spent so much on cleaning supplies, this quarter has gone up by 20%. And you can see, has that been justified by increase in occupancy, or is there wastage, etc.? So your good MIS, management information system, is also key to managing your hospital. Good MIS will show you quarter to quarter, month to month, year to year comparison, this month, last year, etc., wherein you can see where you're growing, where you're losing, not growing, and also your expenses are going up. And it'll also say, okay, my expenses have gone up, but my occupancy is also going up. So maybe it's justified. But if your occupancy is going down and your expenses are going up, then you're in trouble. And yes, coming to outsourcing, one more thing I wanted to mention is, in the US, they outsource a lot more. In fact, most of the hospitals even outsource pharmacy. In India, running your own pharmacy is part of the business model of having a hospital. But there, because they're no longer, even that is not considered core competency. So most of the chains actually have an outlet inside the hospital. So we are going to, doctors also are learning to, doctor entrepreneurs, let me put it like that, are learning to let go give up a little bit more control, wherein they're trusting someone else to take care of laundry, take care of housekeeping. And like Dr. Kishore said, you need to have a few trusted people inside the hospital to run things. And initially, you will have to go through a lot of heartbreak. People you trust might cheat you. So all these things are part of growing pains of setting up a hospital. And welcome to our world.
Yeah. Suresh, my last question is there. Then Prashant Chinta will take, he will ask one question. I know we are sorry. See, since it is a purchasing department, you and Kishore, you are the masters in that. Some people have advised for us. I know that MIS, hospital information system, is there. purchasing department is there. But however, with all those things, some people have undergone very much loss in the pharmacy. And we have seen it also in the hospital. And we cannot hold that fellow responsibility, and who working there also, we cannot hold responsibility. Hardly what we will do. We cannot do anything. They are telling we are not taken, even though camera is there. So even with the hospital information purchase, what is there? How you people, both you people are managing, maintaining in your pharmacy integrity. This is much is there. Every day, morning, evening, you are taking over. Is it possible? How you are doing?
No, everyday stock is not possible because a typical pharmacy or a multi-specialty hospital will have 2,000, 3,000 items minimum. Like I said,
Yeah.
again, you need to have trust at some level and have a trustworthy pharmacy manager. Maybe I'm lucky that I've always had some good people. And they do every day when they come in, they check, do the 2080 rule. Basically, look at the most expensive items that have gone, and they do a cycle count. It's called. There's one person inside the pharmacy who's designated to do stock checks, and he takes the sales of the previous day, goes and checks these items to see if the physical stock tallies with what has been sold and what's showing in the computer. And we concentrate, like I said, only on the high ticket items and not on the smaller ticket items. If there is any shortfall, anything, yes, there is certain penalization. The pharmacy has certain incentive structure, and it's taken out of the incentive rather than just the salary, because you start hitting the salary, they're going to leave you and go somewhere else. So this is where this is how we work. I'd like to know how Dr. Kishore runs his organization.
See, this is a very, very important question which Dinakar is asking, and I think I have to tell you the learnings. When we started Cloud9 15 years ago, we wanted a pharmacy to run 24 hours a day, and we believed that nobody should be, saying that pharmacy is closed and necessity may arise. What happens is 90% of the business happens in the daytime, and 90% of the pilferage happens in the nighttime. So we realized that after a few months, and we started closing the pharmacy at 11 p.m. And then we started having restricted access to pharmacy. As you rightly say, we had CCTV and other things. At the end of 1 year, when we did the audit, we found out that pharmacy was under heavy losses. The chief pharmacist whom we had hired from a reputable multi-specialty hospital with good references. Turned out to be that he was the person who was actually taking away things like, for example, you order a stock, and what happens is, for example, you order something and they'll say, for every 10 tablets, you'll get 2 tablets free. All such schemes he did not show, and he just billed for the 10 tablets, and the 2 tablets which he got free was given to him somewhere else other than the hospital. So over a period of time, none of the schemes, most of the pharmacy schemes were not coming to us, and it led us that we were not making a huge profit in the pharmacy. At one stage, we even thought we will outsource it. And it is a headache, but it takes some time. And that's why you need to have a reliable, trustworthy people managing the pharmacy, because 30% of your income comes from the pharmacy. When I say 30%, the reason is your consumables. You get almost 100 to 200% profit in many of the consumables, and especially the ones you use for inpatient service. So you definitely need a trustworthy person, and you have to keep an eye on it. And there is no shortcut management, as Dr. Suresh says. It is something which you have to go through, and welcome to the club.
Yo. Okay.
Then
So,
one more
Prashant
thing
Chitta, you have one question. Suresh?
Sorry. Just coming back to the pharmacy, some of the things we've done in software, because I know you always ask me about software. We keep close track of what is the previous purchase prices, and because like Dr. Kishore was saying, the pharmacy manager is corrupt. There's very little you can do. So the software tracks each purchase price and raises an alarm if your cost of purchase goes up. And these alerts can be reviewed if you want at the higher level. So if the last 5 purchases were at X price and suddenly the price has gone up, it can raise a flag it can also trigger saying that, okay, if the MRP is gone up, then maybe the purchase price is gone up. But if the purchase price is going up without the MRP increasing, then this has to be reported to the next level. So these are the kind of software tweaks that we've done in our software to maintain a tighter control.
Yeah, I think so. Dr. Kishore or somebody was telling me, or Suresh or somebody in the hotel or in the airport, I don't know. They were telling me if it is 10,000 above every day, we will check. If it is 10,000 to 8,000 every 2 days, we will check. According to your hospital, if it is a multi-speciality, every 2 days, every 3 days, if the stock is very less, like that, we will check every day, we will come to know. So airport or hotel, somebody was you, I think so, either you people were telling. Is it good way? That is the good way to check every day, 8,000, 10,000, 10,000 below.
I think it depends on each organization to find their own comfort level. So there's nothing wrong to start off with, what others are doing. Like you said, high value something. If there's a expensive medicine that is or consumable that is above 10,000, like stents, etc., you check every day, and then settle into a flow that suits your hospital. Because there's always something unique about each organization, but it's a good starting point, I think.
Yeah. So Prashant Chinta, you want to ask some question?
Yes, doctor. This is Prashant Chinta. I'm from Tellercom. We are a technology company offering a lot of wireless solution. So just wanted to understand when it comes to the hospital waste management, including the bio waste and so on, is there already a technology that is there to kind of manage the waste? Or is there a scope for any technology that can be brought? I'm talking precisely from the context that there are two use cases that I could talk about quickly. One, we had built something for the municipality in the Orange County in California that they had all this bins for the waste management kept in the public. Once these bins were always not full for the the pickup trucks to come and pick them up. So there's a scope for building some technology that is again on the Internet of Things, where you would have some sensors which will kind of communicate when the bins are full. That way they could effectively manage picking up of these bins or emptying these bins, number one. Second thing, lately all these IT companies, at least before this lockdown, I happened to see that there is always this food waste that they would want to kind of find an alternate source to dispose them. At least there are these farms where especially the pig farms or places where they would kind of do send this, and again they want to kind of have the employees who are the source for the wastage of this food to be displayed, like what is the kind of consumption that they do and how much is that they're wasting. So there was already a kind of weighing scale that was built inside this bins for the food waste to kind of show what is that they are kind of wasting and how much of feed this could kind of would have helped the number of people who are starving. So that kind of brings in some sense of what the wastage is. Now, combining these technologies, I specifically wanted to understand if there is a scope when it comes to the hospital waste management. Like, for instance, when these bins are full, it would kind of communicate to the management to say like, okay, this is the time when you could have the disposers come in. A. B is there something else that we could kind of think about, or there is a pain area on which we could build some application to improve the disposal methods or the operation in itself? Nitin, perhaps, or any others could help me out with this.
Sure. So like at the start when I said, I've been in healthcare for about 9 years. Prior to that, I spent 13 years in the IT industry. So I can share from both the context. Now, is there a use case? Yes, we can always create a use case. I think IoT is fairly under-leveraged within healthcare in India today. And the extent to which we can leverage IoT, I think sky is the limit. Now, having said that, when you look at it in the context of biomedical waste management, today the entire exercise is happening at a certain cost to me, or to my hospital. Now, will I be, is there, can that be more efficient? Of course, it can be more efficient. Can I be more cleaner with it? Absolutely, yes. Can I make it look more neater, more customer friendly? Definitely, yes. Can it be done through technology? Yes. But will I be willing to incur substantially higher cost than what I'm incurring towards just this because of automation? The answer is no. You won't find too many people willing to say yes to that. Because it's very simple. The entire biomedical waste management or pest control in a hospital, these are all areas which are working on extremely low prices. I can't think of anyone who would say, okay, fine, it's fine, even if the prices go up by 30-40%, as long as I get a much more savvy solution. It's not going to happen. Customers are not going to do it. Like for example, just to give you an example, this transpired just a couple of months ago. I met this company which is into pest control. They said, our chemicals that we use are, much better, much more effective. And, couple of, a couple of times we use it, you will be, mosquito free for about 3-4 days and stuff like that. But the guy said, was quoting almost 3 times or 4 times the cost that I incur today. I mean, granted that his solution was good, was I willing to pay 4 times the price for it? No. So therein lies the answer. While the use cases exist for automation, nobody will be willing to pay a substantially higher cost for it. So that's number one. Second, the entire healthcare landscape, if you look at the entire hospital operations, is littered with use cases which is screaming for IoT and which is screaming for automation. Probably, one of those, yes. Extending the biomedical management technology itself, the technical solution you were talking of, outside of a hospital, when you're linking a lot of other entities and then trying to pool the waste and then trying to source it and then pass it on to the next nodal point, there is a logistics efficiency there, but then that is outside the ambit of a hospital. It's a generic solution, it's cross industry solution. So that's my 2 cents on that.
Yeah.
Just to when it comes to adding or introducing anything new, I mean, especially the technology, technology can never be viewed or put in a OPEX bucket. Always there is a CAPEX that really comes in. Always this technology, as you see, it is the dividend that pays over a period of time. But then it should be, as you said, like sky is the limit when it comes to introducing the technology or even the IoT kind of solution into the hospital environment. Or but the thing is, addressing the pain areas over here, so that the dividend is paid over a period of time, especially when we talk about disposal of anatomical waste, for instance. There is a time period, as I was hearing in this discussion, that what is the safe limit before we could kind of dispose them. I mean, for a dentist kind of application, if you see the amount of waste generated is so low, and they may wait, which is not right. But then when it comes to a surgical hospital, for instance, I mean, the timing, I mean, is important when it comes there. So could this be put in a bucket of OPEX, or it could come in CAPEX?
See, typically this will come in OPEX. I mean, we might look at it differently, or we might want to look at it differently, but it's classic OPEX. And look, like I said, it's not that the use case is an invalid one. Okay, the use case will very much be valid. Is there merit in the solution? Definitely there will be. But the point, again, I would like to come back to is, will I be willing to pay a premium for it? Definitely no. And the reason for that is, just to give you a little bit of context on the industry. Over the last 3 or 4 years, there have been progressive legislations which have pushed the entire industry into a low profitability industry. We are looking at bulk of the industry moving into a 9 to 11% operating margin. And if there are people who are touting 15-16% operating margins today, then they should be garlanded, literally. And when the macro factor is such, literally people are going to be extremely cautious insofar as any spend, and therein lies the predicament. Do we go in for investment and therefore generate value over a period of time, or do we bother about the P&L next month because we are tight on cash? So unfortunately, this is the predicament of the industry at large, and for most players for sure. And that's why I said what I said, which is there aren't going to be too many people who are going to pay top dollar today to spend outside of their core, regardless of the merits of that solution or the merits of the spend.
Yeah, I think so. Thank you very much, Prashant. Nitin,
Yes.
very nice. Pawan, very
Yes,
nice.
sir. One
Okay,
second.
Prashant. I think so. Srinath is there.
Srinath is also there, I guess.
Okay.
Yes.
Anyhow,
Yes, sir.
we learned lot of things. Suresh?
Yes, then I'm here.
Yeah. Suresh, very nice talk. And Kishore sir is very nice talk. Pawan, Nitin is good. Prashant?
Yes, sir.
Yeah, go
Yeah,
ahead,
I
Prashant.
think-
Conclude.
Yeah.
It's Dr. Pawan and Nitin gave the talk. I just made a few comments.
No. They are good, sir. They are good. Pawan and Nitin, they have done a great job. And you sir, your experience counts. Your experience counts.
Thank you.
Okay, thanks everyone.
Yeah, over to you.
Yeah.
Conclude.
Yes, sir. Yes, sir. Thank you very much, Mr. Nitin, Dr. Pawan, and Dr. Suresh, Kishore sir, and all the people who have participated, and Dr. Srinath. It was a wonderful session.
Suresh.
Our specialist in hospital, Dr. Suresh. Thank you very much. Have a great day. And it has been a wonderful, informative session. I'm sure this information is going to help a lot of people who are struggling to understand, struggling to identify their issues or hiccups during their hospital management. Thank you very much once again on behalf of NNF Karnataka. Thank you all. Have a great day.